So this is the Communication Skills 2025 Test 1. Question number 1 is saying, so we are reading this case scenario that is down and then using it to answer the questions. A pregnant woman in labor waited for a physician to examine her. When a male resident arrived, she and her husband demanded a female doctor and sent the resident away. Fortunately, there was a female resident available. She could perform the examination but became frustrated when the woman deferred all decisions to her husband. Delaying care might pose a threat to her and her fetus's health or safety. Evaluation usually involves some subjective questions regarding the mother and the fetus. In this case, deferring all decisions to her husband could severely jeopardize the health of the fetus and that of the mother, since the man cannot know the subjective symptoms related to her pregnancy. Okay, so that is the scenario. A quick summary of everything that is happening here. Here is Mwanza, right, as a doctor. And then we have got, uh, okay, let's say we have got Lydia as also a doctor here. Now, here comes a couple, Crichton and also Mapalo. This is a couple. Now, I want to examine this woman because she's pregnant, but then she can't answer my questions. Instead, she is asking me to ask her husband, Crichton. But goodness is that there's also Lydia, a female doctor, so she takes up uh, the the duty. Actually, Crichton has refused me examining Mapalo, so she asks for Lydia to come and examine her. But then, as Lydia is examining Mapalo, Mapalo is always asking Lydia to say, ask my husband. And Lydia is getting frustrated because there are some questions that the husband can't answer because he's not the one who is pregnant. So he doesn't really understand what's happening within the body of the wife. So, question number 1 is saying, identify the following from the scenario: communication barrier. So, in this scenario, what do you think is the communication barrier? Anyone? Okay. So let's do this. Yes, my good doc, you can go on. Okay. Thank you. Yeah, that is true. So the besides the so for this scenario, there actually going to be a lot. There's going to be an interpersonal barrier, even intrapersonal barrier, even other forms of barriers. But now, when we're answering this part of the question, we need to specify. Say when we say intrapersonal barrier, which specific one are we talking about? If we say interpersonal, which one are we referring to? So we need to be specific. Now we know that when you're talking about communication barriers, these are just factors that are going to hinder the ability to communicate efficiently or effectively. All right. And what do these barriers include? They include the physical barriers or external barriers. Physical barriers will refer to visible and tangible factors. For example, noise, the weather, like the way it is so hot, okay, and then lack of privacy. These barriers are actually going to be able to hinder the way someone is going to deliver the information. If it's so hot, even the way you are talking, you are just uninterested. If there's no privacy, you are afraid of getting to give some forms of information. If there's noise, you are shouting, and that is also hindering the production or the giving of information. Another form of barrier that can be present is a semantic or language barrier. Now, semantic barrier means that you can have people that are just from different generations. right? So if you are saying one thing, it might mean something different for one generation. For example, these different trends that are coming about. Our old folks in society might not understand what we are talking about because these are new trends. Or it can be that I'm speaking something and I'm thinking that someone understands because I belong to a certain region. All right, but not knowing that in their region it might mean something different. For example, if I'm from the northern, I say something, I might think someone understands in the context in which we use it in the northern aspect, but then maybe in the western they use it differently. So those are semantic or language barriers, and they include things like a dialect, which is basically you saying words, but maybe you are pronouncing the same word but you are pronouncing it differently, and that can make someone not understand because the way they know that word is different. Okay, like this thing, I like you. Someone is saying that, thinking, they're just that pronunciation that might be different. Now, I'm not talking about a slang, just a word you pronounce it differently, because the slang is another barrier that is semantic. You also have jargon, because I'm a medical professional. I come and say, from your body, I can actually see there is a pathological disturbance. Bro, just use a language that I'm going to understand as a layman. Okay, so that is a jargon using medical terms. And then acronyms. For example, someone comes and says HIV. HIV maybe is so clear in a lot of sectors. But let's say we say PE. What does PE mean? For someone that is just doing is it CTS, creative studies, physical education, they are going to say this is physical education. For someone that is or in obstetric and gynecology is going to be preeclampsia. For someone in internal medicine is going to be maybe a plural effusion, but normally we are not going to we are going to use it for pulmonary embolism. So these acronyms are actually not good because they might show a different meaning for different people depending on their level of education or the career in which they are. Another form of communication barrier is foreign language or cultural differences. Okay, so cultural differences may actually get to disrupt communication, especially when it comes to the non-verbal behavior. For example, just shaking hands. I've got some friends, Islamic friends, they don't shake hands. Even if you've missed this person so much and then you just want to greet them, they'll just be on a distance. For them, that's it. Because you shaking their hand might mean something different. So that is a cultural difference. And then you have also ambiguity and the abstraction overuse. For example, you are saying something, okay, me, I feel something about you, and then you just end there. Someone might think, what do you feel? Oh, okay, this one, actually, they like me, they go and buy for you a gift. And then when you bring that gift, you just hear, I feel something about you. There's just this hate that is within me. I just don't like you. So leaving things half said is not good. Or making generalizations using proverbs and sayings might hinder communication. There's also information overload. If you say too much, actually, might make someone not understand what you are saying. They can actually leave out the important details and go with the useless details. Okay, and also time constraints. When time is not enough, you are going to be rushing, and as you get to rush in your speech, especially let's say you are trying to communicate medical information to the patient, they might not really understand. Okay, in case even when they want to make an informed decision. Also, there is the interpersonal barriers. Now, interpersonal is basically individual differences. It's inter. So I've got person one and person two. The differences between these two persons. For example, power dynamics. All right. Let's say, for example, we are discussing in a case of you are talking with your consultant and yourself. The way you are going to communicate is going to be totally different when you're talking to your colleague because of power dynamics. There is hierarchy there. Also, things like lack of trust between two persons. For example, this is someone who is your partner. you know, one time they cheated on you, and now this time you see them with the opposite gender. So even if it's really nothing that is happening there, because of the trust that was broken, there might be really a barren communication, conflict, and also poor listening skills. Someone is talking or is interrupting, you know. So find someone who can listen to you. Huh, that is a joke. All right, so that is the thing. And then you have got the in, so that is the interpersonal. You can also have the intrapersonal. Now, intrapersonal is what is happening within you. For example, within you, someone says, you know, you look good. You already start making assumptions. Actually, that person likes me. Okay, so that is an intrapersonal barrier, because anything else that they might say, you are going to be interpreting it in a direction that you have made the assumption in. Okay, also jumping into conclusions. This one is just like this. Also, the attitude that you just have as a person. Also, the perception that the way you view things, or the expectations. You just expect this person, you know, okay, you're supposed to give me this. For example, you are in a simple, you meet this person, they tell you, you look good. You already are planning in your head, oh, in 2 years' time, we are going to be married. You see, those are expectations, so they are going to distort the way you get to interpret, the way you get to communicate. Also, things like stereotype, making generalizations about a group, for example, about a certain gender, a certain age. Also, things like your emotional status. If you are so stressed, you are so angry, you are anxious, it gets to hinder the way you are going to get to understand or speak and get to communicate. There's also bias and prejudice, mental distractions. All these act as intrapersonal barriers. And then you have got physiological barriers. This is just to do with healthy. For example, you have got hearing or speech impairment. Someone is tired or they are ill, or so all these things can act, these are physiological problems that can hinder communication. Now we also have organization barriers. Organization barriers, we can actually also get to drop them into one of these categories. For example, hierarchy, that can be rigid, that can fall under the interpersonal barriers. Poor communication also, that can as well fall in interpersonal barriers. All right, so all those forms of barriers in communication. So for our question here, we want to identify the communication barriers in our situation, in our case here. So some of them include the intrapersonal barriers, for example, the attitude. Okay, like for example the attitude of the couple towards the male doctor, that hindered the communication. They can also be interpersonal, for example the emotions. For example, we've been told in this scenario that the female registrar was getting to be a bit of frustrated because the woman was always projecting the questions to the husband. Okay, other interpersonal includes individual differences. For example, the care provider and the client have different focuses or understanding of care. So the doctor is concentrating on trying to help this patient. The patient is also trying to protect maybe the husband by projecting the questions to them. So those are individual differences. They can as well be cultural differences, like these people. The doctors have got a culture as doctors that they have to follow. Here we don't care whether I'm a male or I'm a female. I'm going to treat you. Okay, we don't care about that. But then for the couple, them also they do care about that. So all those cultural differences can actually get to come in. Number B is saying, so remember here we want to mention from the scenario. So for B, we want to mention one non-verbal behavior from the scenario. Anyone? Any non-verbal behavior from the scenario. Anyone with anything? Okay. So I've not just gotten anyone saying something. So when you come to, we have what we call the channels of communication, because communication is getting to deliver and receive information, isn't it? But how are you going to deliver that information? How are you going to receive that information? So those are the channels. You can either use verbal or non-verbal uh, ways. So for the verb, this is the use of words. Now the words can either be spoken or they can be written. So for you to be able to convey a message. So for example, you can have a face-to-face conversation with someone, or it can be on a phone call, on an email, a text message, in books or publications. Either words which can be spoken or written, those are verbal ways. All right. So when do we use verbal communication? For example, in medical practice. So, verbal information or verbal communication is used to convey clear and direct information. For example, when you're taking the history of a patient, you want to ask about the symptoms, medical background, lifestyle, you get to use verbal, because writing down like the non-verbal, the cues might not really be able to help. Of course, you can also use them. And then you also have explaining the diagnosis. You've told the patient, okay, you have got preeclampsia. So now the patient has to understand, what are you talking about? What is that thing you're calling preeclampsia? How come I have it? So you start now explaining. Okay, this is it. This is the problem you have, and this is what likely would have predisposed you. You is this the first partner that you have? Oh no, this is actually my second partner. Uh, okay, so maybe the changing of partner might have predisposed you. You know, all such things. Explaining the diagnosis, giving instructions. Okay, this is how you use a nebulizer. You are gonna shake it, you're gonna put it in the mouth, and then you're gonna pull, you are going to take a breath, and then you're going to push, explaining a procedure. And then obtaining consent. You don't want just to give the patient a paper and then you start smiling for them to sign. No, you're going to explain to them so that you can obtain consent. And also health education. You want to tell people about it. Okay, if you have got cystosomiasis, this is what would have led for to you having the condition. Are you living near water bodies? This is what you can do to prevent it. Okay, malaria. Can you try to remove all the water bodies, or the stagnant waters? Do you have long grass maybe near your house? Are you sleeping in a mosquito net? Okay. So health education, also team collaboration, discussing the cases. For example, you know that, for example, you want to manage chronic osteomyelitis, and you know that the management is supposed to be actually multidisciplinary. And how are you going to manage that condition multidisciplinary? You are going to bring everyone on board, and then you sit down, you discuss the case. So team collaboration. And also breaking bad news. You don't want to just give someone a smile or just a sad appearance and then they understand that is bad news. No, explain to them this is what has happened. All right, so that is the verbal. For the non-verbal, this involves the communication that does not involve words, anything else other than words. What is this going to include? For example, your body language, which we call kinesics. For example, your body language might include your posture, your stance, your gestures. Okay, also your facial expression. It can show that you are happy, sad, angry, confused. Eye contact. Okay, that can also, eye contact can show interest, or it can show dominance. For example, I look at you, and you know that you're a pretty person. I look at you very much. You might be thinking otherwise. Maybe there might be interest. At the same time, if I'm on the ward myself and the doctor is asking me a question, I'll look at him in the eyes. That is showing me some form of confidence when I'm looking at him, so that I'm not intimidated. So it can mean that. And then you have got the proxemics. This is the distance in space. Okay, this can mean maybe you are close to the patient, not the patient just, but you are, uh, how close you are might mean, you know, you are interested in them, or something like that. And then you have got the haptics, which is communication through touch. For example, a handshake. Okay. And then you have got the appearance, like just your clothing, the grooming, the physical appearance might actually send a very big uh, message to people. Imagine you go with pink hair in the hospital as a doctor. All right, actually, even the way you are, the appearance is going to help us in making a diagnosis about the patient. For example, this patient comes with the hair that is, spaced, and then it is pale and everything. You'll be diagnosing some conditions. There's also what we call paralanguage. Now, when you are speaking, like for example the way I'm speaking, what is making it interesting is not just that I'm producing words. Those words is verbal. But then another thing that is making it interesting is because there is a tone to my voice. There is volume to my voice. And then there is a certain pace and rate at which I'm speaking. That is paralanguage. So it is also a form of communication. All right. For example, if I'm using a low pitch on a particular day, the sound might be high, but if the pitch is low, like if the volume is basically the loudness, I might be loud, but my pitch is low. You get that? I am loud, but the pitch is low. You might say, this is not normally how Mwanza speaks. There might be something that is really happening. And for people that are interested or people that know me, they might come and, Mwanza, in that discussion we had, your voice was like this. What happened? Or in that discussion, your voice was really high. You sound so jovial. Something nice happened, right? That is paralanguage. So when do we use the nonverbal? In greeting patients, you can use smiles, nodding, also in active listening, and this is actually very important in active listening. For example, you are going to be nodding, you are going to be leaning forward. We have what we call the solar. Okay, when it comes to the active listening to show that you are paying attention. And then there's demonstration of empathy. You are going to be making facial expressions during physical exam. Okay, there's going to be a gentle touch and respectful body language. And then imagine you are doing, let's say, pelvic exam, and then you are making these facial expressions to show as though there's something that is really smelly or something like that. The patient might be uncomfortable. And then also managing silence, for example, allowing space for patient to be able to uh, express or process emotions, so it become a bit of quiet. Those are non-verbal. And cultural sensitivity, for example, adjusting gestures, proximity, eye contacts. So those can mean when you get to adjust some gestures, okay, might mean, okay, I think from the culture this is not going to be appropriate, so let's get to change to be able to accommodate this person. And also just for professional presence, for example, clean attire, a calm posture, confidence, all right, the demeanor that is confident, these are also going to show that this person is actually professional. Okay, now before we go back to the question, there's just something again that I want to mention. As you get to communicate, there are also what we call the aids of communication. So besides the modes that you are using to communicate, right? The the verbal and the non-verbal that you've talked about, which are these are actually the channels that we are using to communicate. We also have the things that are going to help us to communicate. We call them aids. These are basically tools. For example, we can have technological aids, which can include hearing aids, speech generating aids, for example, people that can't speak or hear. We can use these technological aids, including things like Twitter, Facebook, emails. This can help us. These are technologies that can help aid in communication. We also have what we call visual aids, for example, charts, pictures, diagrams. We also have written aids like handouts, brochures, posters. We also have human aids. For the human aids, we have got things like uh, uh, an interpreter and a translator. An interpreter is someone that is going to communicate what is being said from one language to another in real time. For example, I say in Bemba, you say in English. And then a translator is going to convert written contents between languages. So for this, like we've said, we also have, when you are communicating, we have got visual aids like charts, graphs, pictures, diagrams that can help in communication. And some of them includes these here, like in medicine, that are going to be important, and we need to know them. You can find one of them, right? Okay. Okay, so that is that. So back to our question, which was saying one non-verbal behavior. So for the non-verbal behaviors, as we said, we can have things like touch, body language, facial expressions, and the main that we have discussed. Then the question says the channel of communication. So for the channel of communication, we can either have verbal or non-verbal, isn't it? So for the verbal to be specific, we use the words. That is the channel. Okay. That is the channel of communication in this case, because the doctor was actually talking to the patient. The patients were also responding to the doctor. So the channel were words. We've not been told that there are posters in this case or something like that. And then for D, it's saying the level of communication. Now, when you talk about levels of communication, we have got things like the intrapersonal communication. This is communication within yourself. How can you communicate within yourself? That is a level. It's like thinking or reflection, meditation. There's also the interpersonal. Now, interpersonal is two-way, where there is face-to-face exchange. For example, I'm talking to someone, all right, in person here. So that is going to be interpersonal. And please take note, it's two-way. For example, in a conversation, a discussion, an interview, and this one requires active listening. And it requires that you show some empathy, mutual respect. There's also what we call the mediated communication. Now, for the mediated, it's also two-way, but then it's not face to face. Okay, there's a medium. For example, using emails, reports, phone. Okay, for a phone, uh, you are going to be talking to someone, but then the person is not here. So there is a medium, including also on an email. WhatsApping. You are talking to someone, but no, they are not there. There's also person to group. This is one way. Like it's a person sending to a group. Like currently, what is happening right now? I am talking and then we are just listening. So this is a person to a group, right? So it can either be face to face. So if this person to group is face to face, then that is, so I've got the person to group. This one is one way and then it is face to face. But the way it is currently here, it is one way, but then it's not face to face. This is mass communication. I'm talking and then a lot of us are listening currently. And we are not face to face. So this is mass. I'm talking to many people who can't respond. Otherwise, for a person to group, the group should be there face to face. Okay, so these are the levels of communication. So in a case like in our question, the doctor is talking to the patient. Okay, doctor to patient. So that is interperson, because there is actually two-way and then it is face to face. All right. So number two is saying explain the role gender played during information sharing. Anyone that can help with this one? What was the role of gender in information sharing in our scenario? Anyone to help here? Okay. So do remember what is happening in the scenario is that the female doctor is communicating with the woman, but she's projecting to the man. So this is some gender that is happening here. So what is the role of gender in this case? So the man in this case is performing the duty of the head by being the one who is making decisions, right? So he is acting as the head. So that's the role of gender. Gender demands that each one plays their own role, these gender roles. Okay. Of course, when you talk about gender roles and sex roles, for gender roles, they are going to tell you, for sex roles, these are just things that a man alone can perform and a woman alone. Things like giving birth, breastfeeding. And then when it comes to gender roles, this in our generation, this is where we want even where people are fighting to say what a man can do, even a woman can do more and such. But then in this case, it is giving authority to who is supposed to head. So for this, for the role of gender is where you are taking one to be not really subordinate, but you are putting one as being the head and then one as being led, following the leadership. Okay, so the wife in this case was taking the role of being really accepting the role of the husband as being the decision maker. All right, even in her health. And this is actually a problem because it was compromising proper health delivery, because the husband does not understand how the woman is really feeling, though those symptoms are subjective. Okay, and also the tendency of the man to protect his family, or when the male doctor was coming to try to ask or to take the history from the and examine the woman, but then the man came in. So that is again the gender that was playing a role there. The man was protecting what he thought was his, right, from even from the male health pro, pro, healthcare provider. Besides that, pregnancy is attributed, we know, to womanhood. So when the man said, I don't want the male doctor to come and attend to my woman, instead let a female doctor come to attend, at least because you know that a female doctor is going to handle the woman, at least whatsoever the man was thinking, there is a womanhood there, right? Like pregnancy has to do with being a woman. So even someone that is coming to treat the woman should be the woman, so that is concerned with womanhood. So that is again the role that gender played in this case. So the couple decided that the female healthcare provider gets to interact with a female patient, okay, irrespective of the training or the skills. So that is also another role that gender played in this case. Number three is saying, identify what made the situation in the case scenario difficult. So again, as we've mentioned, the woman was projecting the information to the man, right? Was projecting the question to the man to make a decision. And that wasn't good because it was not easy to collect appropriate information, because the client was not responding directly to the okay, the client couldn't respond well to the questions because it was subjective. You are not the one that is pregnant. You don't understand the symptoms. So again, what was affecting in this scenario is the beliefs and the cultural role. Maybe the man was thinking in their culture, if this is a woman supposed to be treated or taken care of by a woman doctor. And so the role of beliefs and the culture played a role, including also the role of gender. So that one was bad because it was inappropriate, okay, because it didn't allow the doctor to be able to get full information when the questions were being directed, considering the gender roles, the cultural roles, and also the beliefs of this couple. So the big problem here is that information couldn't be delivered as much as it should have been delivered because of these barriers. And then discuss the difference in the communication between the doctor and the client family in this case scenario and the Indian camp. Anyone who can give us a summary about the Indian camp. Anyone? Just a quick summary so that we can relate. Yes, my good dog. Sure, please. Mm, okay. All right. Thank you so much, my dog. Thank you. Is there any other thought from anyone? What do we think the difference between what has been described in this scenario and also the Indian camp? Anyone? Okay. Now, as a quick summary about the Indian camp, right? It's a story about Nick and also his father, who is a doctor, right? And also his uncle, who was George. So we have got Nick, who is a they call him young Nick, his doctor father, and also his uncle George. Okay. So these guys, they rode across a lake and then they went in a nearby camp. And then when they arrived in that camp, which was shanty, where a Native American woman had been in pain because she was in labor for 2 days. So her husband, who has actually suffered an axe wound to his feet, was lying on just on the bed above her. Right, so I've got this pregnant woman, she's in pain, and then the husband who had injured himself. So what happened is the doctor wanted to help by doing an emergency operation, right? So why did they want to do that? Is because the birth was not progressing. So Nick's father had to perform an emergency C-section on the screaming woman, and they had to use a knife with Nick assisting. So after the baby was successfully delivered, Nick's father discovered that the woman's husband had killed himself by slitting his neck, his throat with a laser. And then the story went on where Nick, started asking some questions and such. So that is just a small summary about this Indian camp. But one thing that you is going to be a difference between the Indian camp, what happened in the Indian camp, and also in this scenario is, remember in this scenario, the doctor came, the male doctor came, was refused to do the procedure and then just left. The female one came. Different from the Indian camp. Okay. So for the Indian camp, the doctor did not explain anything about the procedure that was to be done. Actually, there was no anesthesia that was even used. So there was no communication at all. The doctor just went and did the procedure. But in this scenario here, the client was actually being talked to, right, by the doctor and was also involved. And also the partner for the client in this case was also involved in making the decision. So the client decided on a care procedure, and also there was autonomy here. So there was independence in the making of the decision. It was not forced. Okay. So that is what happened. So there was actually an interaction in this case between the doctor and the clients. So because there is an interaction here, I want us just to review what we call communication models. So for the communication models, we have got three main types of communication models. A communication model is just a framework that is structured to explain how messages are going to be transmitted from the sender to the receiver and also back. So I've got the linear model, which was proposed by by Shannon and Weaver. Now the linear model is a one-way communication model. Okay, it is one way. So this one, you have got the sender and the receiver, but the information is not sent back. What is an example here? This one is used, if, for example, in mass communication, where we said, like, for example, the way I'm speaking now. At points, I'm only speaking, you are not responding, right? And also in giving a speech, if someone is delivering a speech, there's no time for people to respond. Okay, so that is linear model that is used. For interactive model, this one is two-way, where you get to speak and then there is feedback. But one important thing in this kind of communication is that there's going to actually be, because for you to respond or to give feedback, there should be active listening. How do you know that someone is actively listening? They are going to be giving feedbacks. They are going to be giving acknowledgements. Things like, okay, oh, so you actually mean this. Okay, you are discussing, there's also paraphrasing. Oh, so do you mean this? Okay, this is what you're trying to say. And also parroting. Parroting is giving back the words that someone is saying. Okay, they giving back the sender's words. For example, okay, so you are basically trying to mean this is what you are trying to say. Okay, you had actually said this, that preeclampsia is where you have got a BP of this. Okay, okay, I understand. That shows that someone is actively listening. So that is the interactive model. When do you use it? For example, on a phone call. On a phone call, you'll not be talking for 2 hours. Like, for example, I talk on phone with some people for 4 hours. 4 hours you are talking, and you can't talk for 4 hours alone. It's not possible. If I'm talking to my mom, I can be talking to her for over an hour. It's not possible to talk like that when you're talking alone. It's where someone is, speaking, you're also listening. And the thing is that for this one, there's actually going to be some noise that you're going to be overcoming, which we call barriers in this case. So the one who is sending information is actually encoding, and then the one that is receiving is decoding, and then the receiver can actually be the sender again. In a transactional model is a form of simultaneous communication. This one is actually a very good communication model, because this one, the model views communication as a continuous process where the sender can act as a receiver and back and forth, right? So both parties are senders and receivers. So this one portrays communication as a dynamic process where the sender and receiver plays the same role simultaneously. Okay. For the interaction, no, I'm going to say something. You get to respond. And then, so I have said something to you, you listen. And then you get to respond when I become quiet. But a transactional, this is simultaneously happening. It's not like I'm just saying you listen and then you get to respond. But I say something, you are listening. You also say something. Like there is a response. At one point, I listen to you. You respond. At another point, the me was listening, or the me who was speaking is now the one who is listening, and then we are talking back and forth instead of just responding. So that's a transaction model. Okay, and then we are going to have, of course, so here I've got communicator 1 and communicator 2, where communicator 1 can be a sender and receiver at the same time. Communicator 2 can also be a sender and receiver at the same time. And then we are going to have the message going in the forward and back direction. So that is on question number 1. Is there any addition or questions on the first question, question 1? Okay, so question 2, we've been told to critically analyze the picture below and answer the questions based on it in the spaces that will be provided. So we can see what is here. I'm guessing this is our good dog here, and then this is our patient or our client. So number one is saying identify only two components of active listening that we can see from here. Anyone, any component of active listening that you can see from here. Anyone? All right. Thank you so much, my good doc. Yeah. So he has said, just the leaning forward of the patient, and then also having some eye contact, and just the okay. So those are some of the things. Is there any other thing from anyone which shows that there is active listening here? Okay, as our good doc has said, so just something when it comes to what we call effective listening, which is of course when you want to listen well actively, we are using this effective listening. So what is effective listening? When the message that is sent to the patient or to anyone that you're communicating with is going to be understood the way the sender intends it to be understood. That's what we call effective listening. So for you to effectively listen, there's need for to pay attention. All right. So effective listening is if I'm saying something, you've not just gotten it, but you've gotten it the way I want you to get it. Okay. So in effective listening, we have got what we call active listening. For someone that is active listening, we can actually use what we call solar. There is S being uh, the S is squarely. So you face the other person squarely. Like you don't sit straight facing straight, like one on one, like some you are here and then someone is in your front. No. Just like they have sat here, like a square, you see. Okay, that is sitting squarely. And then the O is the open posture. Okay. Like for example, the way the client has sat here, they are really free. They are even putting their legs properly, okay, in a comfortable manner. And then the L is towards the other patient or the other person or lean forward. The E is maintain eye contact. And then the R is be relaxed. Okay, while paying attention, you are relaxed. Other forms of effective or active listening includes appropriate non-verbal communication. When the patient, when someone is talking to you, you are responding to them, for example, using parroting, or you are repeating what they are saying, you are agreeing, you are nodding your head, okay, using appropriate voices and tone, and also communicating the client level, communicating at the level that someone is talking to you, communicating at the level of the person that is talking to you, like avoiding jargon. That is also another form of active effective communication. That's effective communication, but really that is not active listening. For the active listening, is them talking to you, isn't it? So their language obviously is not having any jargon. Also giving facial information, not assumptions. Okay, so like making these facial expressions to just mean that you are together with the patient. Also using reinforcement, things like smiles, nods, compliments, as we said earlier. So those are some of the things. Okay, so those are things that have been also mentioned here. Eye contact with each other, the posture leaning forward, okay, indicates concentration, facial expression, all right, and body language, like for example, leaning forward, and also silence, body posture, also close the door. Okay. For a closed door, it is going to indicate uh, our good doc has written say privacy. That is also important in active listening to avoid disturbances. Okay. Also, the listener faced the speaker to indicate interest and focus on the speaker. Okay. So those are ways in which you can, those are the components of active listening. Number two is saying identify two pieces of information a client could infer from her posture. So what can the client deduce from just the posture of the doctor? What would be the interpretation from the client's perspective? Anyone? Yeah, like just that posture is going to show that someone is attentively listening, and then they are interested, right? They're interested in what you are saying, and also uh, they are relaxed. So they are in just the posture in which the doctor is, where they are relaxed. When you're using the solar, it means that she's actually listening. So the patient or the client is going to interpret just from the posture that there is attentive listening because of leaning forward, and also that this person is actually assentive. Now assentive means this is actually assertive. It really means you can give your views in a way in which you're not hurting someone, at the same time you're not saying something to just try to protect someone. So when someone is speaking, you get to listen to them, they say what they want to say, and then you also, get to contribute. Okay, I think this is what I also feel. So she just a posture for leaning forward, crossing the legs, that seems assertive. Okay, also relaxed means that they are actually listening, and also leaning forward means that they are paying attention. Okay, so those are some of the things. One state one time a healthcare professional can use verbal communication. So as we had said earlier on this one, for verbal communication, for example, when you're taking history, when you need to find out about a client's problems, needs, when you want to respond to questions, contribute to team meetings, break bad news, provide support, you know, uh, deal with problems and such. Identify two non-verbal cues that suggest active listening. And we've mentioned them really for the non-verbal things, cues. Non-verbal. For the non-verbal, we talked about the communication really, which can be non-verbal or verbal. So for the non-verbal, we had mentioned a lot of things like the posture, the privacy, the proximity, right? Even things like the tone, the paralanguage. What level of communication exists in the picture? Now, for the levels of communication, so we need to know the difference because sometimes we can confuse them. We have got the levels, models. Which other one do I want to talk about? Okay, so for the levels of communication, this is the interpersonal, intrapersonal, and such. So in this case, this is an interpersonal because you have got the doctor and the patient, just the two of them. If it is just thinking, that will be intrapersonal. If you are talking to a group, that will be either a mass communication, depending with whether it's one to one, whether you are seeing them face to face, or it can just be one to group. And then what model does the picture depict? A model of communication where you are listening to what someone is saying, and then they also listen to what you are saying, and then it is a continuous communication. That one is transactional. because it's actually the best way one that we use when you're talking to patients. You're going to talk to them, you give them what you think as a doctor, but you also listen to what they are saying. It's different from interaction where they'll probably just be answering, or the linear model where you're just saying alone. Imagine the man in the picture has an essentialist view of gender and refuse to inform the female healthcare professional about the difficulties. What does essentialist view of gender mean? Anyone who can help us with this one? The essentialist view of gender. Anyone? Okay. So the essentialist view of gender is the belief that men and women have inherent, fixed, and unchangeable characteristics. Like the way you are just born as a man and as a woman, you have just features that we can't change based on your biology and nature. Okay, so this one suggests that these features, which we call essences, will dictate the way a person behaves, your personality, your roles in society, your identity, instead of your social status. So, according to the essentialist view of gender, doesn't matter if you are educated or you're not educated. By nature of you being born as a male or as a female, you have got certain roles that you play, your identity, your behaviors that you're supposed to portray. So this one, it tells, so in this case, gender is one's genetic constitution. That is the essentialist view. Okay, like your gender is your is your genetic constitution. Hence, men and females have different roles and identities that shape their communication and behavior. So that is the essentialist view. Just the way you are born, that will tell your behavior, your personality, your roles, your identity, and that actually affects your communication. 8 is saying identify one type of interpersonal barrier that could disrupt the communication process. Now we know for the interpersonal, because different from intrapersonal, the interpersonal includes things like assumptions, jumping to conclusions, your attitude, your perception about people, your expectations, stereotyping, emotions, your biases and prejudices. Okay, mental distractions, for example, now, for this one, the internal thoughts and worries, these ones are mostly going to fall under intra. Or actually, this is intrapersonal. Yeah. This question was asking for interpersonal, not the intrapersonal. Okay. Yeah. So for the interpersonal, so this is supposed to be not here like this. The interpretation includes like making assumptions, jumping into conclusions, attitude, the attitude to with people, your emotional status, all this can get to affect the way you get to interact with people. For the internal thoughts, that's mostly intrapersonal. And then the last question, that's question three, we want to put true or false on each option. So question one is saying interpersonal barriers are barriers unique in to an individual. This is intra, and we know intra is within an individual, right? So that is it's true. And then silence does not contribute to effective communication between a doctor and the client. This statement is not true because silence is actually a form of communication. When you are delivering information and then someone becomes silent, it might mean maybe they are trying to process what you have said. Okay, so I need to give them time. So it contributes to effective communication. An 85-year-old Mr. Banda cannot be categorized as a vulnerable patient because he still manages his farm in a car without his children interfering. Now, this is not true. Just because you can manage yourself minus interfering doesn't mean you are not vulnerable. There are groups of people that we are going to classify, so that we can be able to pay attention to them. For example, The pregnant are going to fall in a category, in a certain category. The elderly, like those who are above 65, by nature, by reason of this Mr. Banda being above 65, even if he can take care of himself, we will classify him into that category, so that because just in that category of them being elderly, there are some things that they are likely to suffer that everyone else can't. So they need to be taken care of. A clinician's voice may deter a client from sharing information. That's true, right? Just your voice. If you are shouting, if you are low, you know it will tell if you are upset or if you're uninterested, just your voice. So it actually can hinder the way a client is going to present information. Miss Walia served as an interpreter to Paul, a fourth year medical student who does not understand laws. Miss, or this is Miss actually, Miss Walia is an alternative form of communication. Now, this is not true. Miss Walia is serving as an interpreter. An interpreter is actually a human aid. They are just helping in delivering information. They are not an alternative form. Okay, they are just an aid. In the Harvard style of referencing, titles are italicized, not the journal name. Now, this is false because the title and the journal name, both of them, are going to be italicized. To collect accurate accurate information when the client is a child, a clinician must observe the child's parents or caregiver. Now, this can be true. Uh, This is a child who is sick, isn't it? So, if you're observing the mother, how is that going to tell you about the condition of the child? You actually observe the one that is sick. Maybe if it was asking questions to the caregiver, that would be true. A prolonged and frequent period of silence during history taking means reflection. Now, it might not necessarily remember if someone has got, you're talking to them when you're taking history, and then they have got a time of silence. It might mean they are trying to process what is being said. But now, if it is so prolonged and frequent, it might not mean reflection. It might, maybe it's a condition, or maybe they are not interested. Okay, gender is one of the factors that affect communication. From childhood, the man is trained to establish dependency, which could affect their interaction with a doctor. Now, this statement is not true because gender is one of the factors that affect communication. That is true. From childhood, the man is trained to establish dependence. A man is actually trained to establish independence instead of dependency from childhood, and that is how we get to, as we get to grow, we want always to show leadership. Collaborative healthcare is not characterized by professionals assuming complementary roles. Now, this statement is false. Collaboration means that professionals can actually come in and perform different roles that are going to complement each other. For example, you have got a pathologist, you have got a pediatric surgeon, you have got, let's say, a general surgeon, all these coming together to treat a certain condition. They're complementing each other. So that's collaboration. It is characterized by professionals coming together to complement each other. 11 says the closer in space, the less intimate the relationship between the clinician and the client. Now, proximity means there's some form of intimacy there. That's why you don't have to be so close to the patient. When you are clicking, when you're taking history, you are even sleeping on the bed, imagine, of the patient. It doesn't happen, of course, because we know this. Information sharing and receiving occur simultaneously in the interactional communication model. This is false. For information sharing and receiving that occurs simultaneously, simultaneously is the transactional model, not the interaction model. Symbols and signs are graphical ways to communicate this information, especially to those who cannot speak or understand a particular language. False, right? Its symbols and signs are graphical ways to communicate information, right? Not disinformation, especially to those that I can't understand in a particular language. Bad news depends on the prognosis and how the physician perceives it. Is that true? False. Bad news is bad news, right? Bad news does not just depend on the physician's perception. It is bad news because that's how it is. For example, if I come and tell you you have you are going to die, sometimes like health practitioners, we don't even have emotions sometimes. The emotion, because you've dealt with so many emotions, so you might not even perceive it to be that bad, right? But it's still bad news. That is it. From the It might be from the patient's perspective, but even just from the medical knowledge that we know, this is bad, even if your perspective might say otherwise. Some news is actually bad even if the prognosis is good. For example, someone has got a condition that is at stage one. Let's say they have got a cancer stage one. And for the staging, if it is low, it means the prognosis is good. But this is still going to be bad news because this patient has got a condition that they didn't have or that they wouldn't want to have. 15 is saying a clinician who made a medical error should not inform the patient because the patient would no longer respect him or her. This is not true. If you've made a medical error, you're supposed to, there is a way in which you can tell the patient. Yeah, there is a way in which you can tell the patient, and even if they might be a bit of disappointed, but at least they know, they are aware of what has happened. So always, hiding information is not right in any case. 16, it is impossible for a healthcare worker to detect some underlying tension that belie a patient's words through voice inflections. Now, this statement is not true because it is possible for healthcare workers to detect underlying tension just from the way the patient is talking. A healthcare provider can actually tell what might be wrong with the patient. That's why paralanguage is important. 17 is saying the education and socio-economic level of a patient have little or no effect on their communication with the physician. This is not true because education and social levels have a lot to do with the way you are going to communicate. If you're talking with the illiterate, it's different from when you're talking to the educated. Totally different. So it has got uh, an effect. 18 is saying society establishes different means of communication for the sexes from infancy, and this is true, right? Like the one we said that we have got the essentialist view of gender, where just from childhood you are trained a man, because you are a man, this is how you behave, this is how you communicate. Even up to now, some men still know that you don't negotiate with a woman. You're supposed to say things and then she listen to you, and such things. 19 is saying a physician should be less concerned about making ageist assumption when dealing with the elderly, but more concerned with providing care. This is not true. A physician is not only concerned with providing care. Just based on the age, there are also assumptions that you can make because depending on the age, there are some things that likely. Now, these assumptions are really not that you get to judge them, but to help in making a proper diagnosis, to help in making to giving a proper care. For example, in a certain age, we know if we're talking about, let's say, chronic osteomyelitis or just osteomyelitis in the teenagers or in the sexually active, because of the age, you can make an assumption of what might be the probable cause of the condition. That is age. If you come again in the older, the same. Okay. Number 20 is saying Every well-intended cultural practice that a parent conducts on a child for therapeutic purposes, even when it causes serious harm to a child, is not child abuse. This is not true. Child abuse is so every well-intended cultural practice that a parent conducts on a child for therapeutic purposes, even when it causes serious medical harm, that is not true. So that is actually going to be child abuse. This is saying it's not child abuse. So things that are going to cause harm, that is an abuse. People from high context cultures are individualistic, analytical, and focus oriented. Again, this one is also false. People from high context cultures, this is more prejudice where we're making this generalization because you think if someone comes from a high context is going to be, you know, uh, individualistic, right? Of course, if you come from a high context culture, you might be there is a different way in which you're going to think from everyone else, but we can't make an assumption that you're going to be individualistic because that would be prejudice or judging. High context culture conveys meaning through an explicit verbal code. Again, this statement is false. High context culture conveys meaning through an explicit verbal code. Now, okay, I'll have to mention something about the verbal code, but first, number 23, to accommodate others' differences, physicians need to reverse their interpretive framework. This statement is true. So, to accommodate oth- other differences, physicians need to reverse their interpretive framework. Now, this is generally true about life. If you There's a way in which we interpret things, there's a way in which we think about situations, there's a way in which we analyze situations. So, if you are going to accommodate many people, if you are going to be in good terms with many people, you should be able to reverse the way you get to interpret things, right? The way you get to think about certain things if you want to accommodate people. For example, you discover that you are arguing with many people if you just hold on to one principle that you believe is true and you don't want to think it can be any force. Okay. And then 24 is saying accessories such as tattoos, handbags, and earrings can indicate a lifestyle but cannot predict medical condition. This can actually help to predict medical conditions, like things like tattoos, earrings, handbags. Maybe this one is mad, but that's not the case, anyways. But the general appearance of a person can actually get to help us in making predicting what is wrong with them. So on the previous question that I said you have to say something about them. Explicit verbal code is just a style of communication where the speaker, the speaker's intent and the message's specific content are stated directly, okay, without reliance on unspoken content. For example, when you are speaking, you are going to think, okay, someone should understand from like this is how ladies like behaving. They are saying something and then they are also making they are giving you this body language. They want you to interpret from the body language when they are saying different words. So for the explicit verbal code, it refers to you getting to make communication that is going to be understood clearly, okay, without relying on unspoken context. All right, so that is the explicit verbal code, and that's 23 saying high context culture conveys meaning through an explicit verbal code. So his statement is false. High context culture might not convey meaning through explicit verbal code. They might just, sh- you know, I'm rich. I'll just, okay, this. I expect that you understand from what I've said. A simple statement. I expect that you understand. Okay, so that can act also as a barrier to communication. So many times when you want people to interpret what you are saying in a way you are thinking, it might not be proper. So just say it direct. Be clear. I like you. I like you. Not you are showing a symptom and then the signs are different. All right. So this is this paper 2025 test one communication skills.